Good morning, good afternoon, good evening, all the colleagues around the world and in Australasia. Thank you for joining us again for another TAPS, the Australasian Plural Seminar Series, geared towards our plural colleagues and anybody that really wants to just be involved and update their knowledge on plural disease management. Today, we have the pleasure of having Dr. Sanjeevan Muruganandan talk to us about pain in plural management and plural disease management. He is the plural and research lead in the Department of Respiratory Medicine at Northern Health in Victoria. He's a clinical fellow in the Faculty of Medicine, Dentistry, and Health Sciences in the University of Melbourne. So we're excited to have him talk to us and describe about kind of how to best delineate pain management in patients. Before I hand off the mic to him, I do just want to kind of remind everybody that all of our sessions are recorded and are uploaded to YouTube for further review if you're not able to meet the sessions. But with that, I will hand over and give the mic to Sanjeevan.
No, thanks, Dhaval. I'll share my screen. Does that work?
Yep.
Yep. Um, all right. Thank you for the opportunity to sort of present in this forum. So I'm going to talk about intervention to improve pain control in the management of plural procedures, which most of us commonly do on a day-to-day basis. Um, all right. So plural diseases it's common with a rising case frequency, often associated with significant impairment in quality of life. Individuals with plural diseases often require diagnostic or therapeutic plural procedures, and this may include intercostal catheters or an IPC, indwelling plural catheters, bedside pleurodesis, medical thoracoscopy, ultrasound plural biopsy, and over the last decade or so, intrapleural fibrinolysis. Um, so pain is frequently reported in Hooper et al. In 2015. Jenny describes about 1 in 10 during ICC insertion and at least 15% post procedure. Pain occurs presumably at these procedures require direct access to the pleural cavity, and various interventions to minimize pain have been reported, but there remains no standardized method for pain control. The parietal pleura is particularly and can be executively painful due to the heavy innervation by somatic intercostal nerves and endophrenic nerve. Um, so pain during non-surgical probe procedures, we think is mainly primarily due to the direct irritation to the pain fibers innervating the skin, parietal pleura and the periosteum, and that's where our local anesthetic tends to predominantly focus on. The direct irritation from instrument manipulation, local inflammatory reaction. So sometimes when you get a PET scan after a probe procedure, you can see some degree of metabolic activity on the lining of the pleura, um, even without underlying particular cancer nodularity or parietal nodularity. And also during drainages, large blow pressure swings during rapid or large volume drainage. In terms of, I guess, to sort of give you a thing of how frequently we perform procedures, so this was a study retrospectively done by Fontaine et al. In Canada, where they looked at the Canadian Registry of Admissions, hospital admissions, and there were 72,000 procedures performed in just MPE patients alone, and um, majority of the procedures were therapeutic thoracentesis, which is catheter over needle, but ICC insertion, chemical fluidesis, about 14%, and out of which 57% were bedside and another 43% were during thoracoscopy. And medical thoracoscopy is over 10% of all procedures performed during the year. Um, Now, in terms of measuring pain, unfortunately, we don't have a perfect measure. We definitely don't have a subjective way of measuring pain. Um, There is an MCID that's set for chest discomfort post thoracentesis, which is set at 16 millimeters based on a VAS scale with the 100 millimeter anchored towards pain imaginable and the zero at no pain at all. And this measure can look quite different depending on the studies that were used. Um, Now, the only thing is this can't be generalized to other forms of closed procedure, which is often done and used to most studies. And the other more common measure of pain is the numerical rating scale. There are also two other studies in trauma patients where they looked at acute pain in the emergency department, where they found a difference of 13 millimeters on the visual analog scale, represented a minimum change in acute pain post intervention. So why do I think pain control is important? It can negatively influence patient perception and experience of pro procedures, which does can sometimes impact for further procedures, especially in MP patients who might require two or three other procedures during their diagnostic journey. Um, there can also be prolonged periods of immobility due to pain, which can impact hospital length of stay, may increase risk hospital acquired complications given they've been in hospital for a bit of time, and also deconditioning, as two studies from Gary's team that found still highly sedentary behavior despite therapeutic interventions over the 30 days. And also the increased rescue use of increased rescue analgesia, especially opioids, and the risk of death in the patient population going forward in the long term. So the presentation was really focused on on this paper that we published, looking at pain control interventions for non-surgical pro procedures. What we The research question was, what's the best way to reduce pain during pro procedures? We searched a few databases and limited our search to English only, and our search strategy looked at analgesic approaches which combine terms relating to outcome measures and specific to the procedures itself. The studies were included if they involved adult patients aged 18 years or older with Crohn's disease, if participants were undergoing non-surgical procedures, if they assessed an intervention that influenced pain, or if they had an outcome that measured pain scores and patient experience. We excluded review articles or studies that involve pediatric trauma or surgical population, such as bad tracheotomy. Just a quick summary on the Prisma flowchart. So we 873 results were identified from the database search. We removed After removing duplicates, 482 studies were left for screening. For a large majority of them were excluded, and 23 studies were for full text review. Um, and we Four were further excluded because of either wrong patient population, wrong intervention, or the study is still in progress. And there was 19 um, studies that included in that review. So what we found was 12 randomized controlled trials, four prospective studies, one retrospective cohort study, and two case reports. Um, the we categorized the categorized it by pro procedures, um, and the main one being medical thoracoscopy, chemical fluidisis, pro catheter insertion, either an ICC or an IPC, and pro drainage. Um, as you can see, there's a lot of heterogeneity in terms of intervention type and outcome measure. There were no studies looking assessing pain control, intrapleural fibrinolysis, or pleural biopsies uh, per se. Just to note that with intrapleural fibrinolysis, people can get substantial pain, but not, and I think it's in the order of 10 to 25%, but still not well studied. So going to medical thoracoscopy, we looked at, so there were three RCTs and two prospective interventional studies. And the medical thoracoscopies that's included in this part of the presentation were mainly diagnostic and therapeutic, mainly adhesive lysis. They all had ICCs inserted post procedures. The randomized trials used a VAS score, either using centimeters or millimeters, from no pain to worst pain possible. In terms of interventions and the agents used, so again, a wide variety. So it goes from local anesthesia and a combination of multi-level paravertebral blocks using bupivacaine and mepivacaine. Also sedatives of propofol with a bolus and then a continuous infusion, as well as midazolam. Some studies use intrapleural anesthesia. There was one study that looked at inhaled analgesia, which is Pentrox, and one study looked at the thoracoscopic instruments between mini thoracoscope and a semi-rigid thoracoscope. So, looking at perivertebral blocks, Abu Zaid et al. In 2017 looked at compared three-level and two-level perivertebral blocks, and they both demonstrated lower pain scores than just infiltration alone, local anesthetic alone for thoracoscopy. And this procedure is performed without sedation. I don't think there was no significant difference between the two-level and the three-level perivertebral block in this study. When you looked at there was no significant difference seen in pain scores between using propofol and midazolam. However, there were those receiving propofol required less breakthrough analgesia. Intrapleural anesthesia with lidocaine was more effective at minimizing pain than midazolam, and those participants required less analgesia post-procedure. In terms of thoracoscope size, the mini thoracoscope was shown to be more painful than the semi-rigid thoracoscope during thoracoscopy and under sedation. Just for, I guess, ease of looking at the scales, I've sort of reported, these two studies were reported in centimeters, but I've just changed it to millimeters. So, and going into chemical fluidesis, there were four RCTs, one prospective interventional study, and one case report. They're both thoracoscopic and non-thoracoscopic fluidesis. The main sclerosant was used for stout, and there's also one that used tetracycline. Again, the randomized control trials used the VAS score, either using centimeters and millimeters, a numerical rating scale from 1 to 5, and a 4-point categorical scale, and as well as a questionnaire. So again, a wide variation in sort of outcome measures. The intervention studies included intrapleural lidocaine, non-steroidals, opioids, different chest tube size, and also transcutaneous electric nerve stimulation when the chest tube was in place. So, with regards to intrapleural lidocaine, this was found to be more effective, found to be an effective analgesic with better pain relief at a higher dose of 250 milligrams compared to 200 milligrams. It was also seen to be well tolerated and administered via a spray catheter. In terms of pain relief, pain relief was not significantly different between non-steroidals and opioids, although the non-steroidal group required more breakthrough analgesia. Chest tube size did not appear to make a difference to pain experience during the installation of the sclerosant itself. And in terms of TENS, it was found to be more effective as an adjunct to non-steroidals, anti-inflammatories for up to 8 hours post-procedure. In terms of full catheter insertion and removal, ICC insertion and removal, there were four. So 8 studies explored pain control while the ICC was inserted in situ, and 3 studies looked at pain control during ICC removal. The interventions studied included, again, various chest tube size, intrapleural bupivacaine with and without adjuncts, methoxyflurane, hospital protocols, and cold application with ice. Again, the RCTs used either a VAS measurement numerical rating scale from no pain to worst pain possible. So multiple studies demonstrated that smaller bore intercostal catheters. Like 10 to 12 French cause less pain than larger bore ICCs. And this was both during insertion and while it was in place. Um, in terms of ICC insertion, methoxyfluorine, so which is the green whistle, in addition to the local anesthetic, demonstrated a reduction in pain scores in intercostal catheter and IPC insertion, as well as thoracoscopy. This was just so far it's only been in an abstract form, and larger prospective studies are needed to validate this intervention. And another study found that a revision of the hospital protocol, which included staff training, essential pre-medication, a max safe dose of local anesthetic, and proper injection techniques, resulted in less pain post-procedure. In terms of intrapleural anesthesia, two studies both found that intrapleural bupivacaine was effective in reducing pain while the ICC was in situ. So in this study, you can see here that bupivacaine has lower pain scores than normal saline, which is a dotted line, and at least an hour. And another study found similar results for intrapleural bupivacaine, but further found that addition of morphine or dexmedetomidine extended the duration of analgesia for up to 15 to 8 hours, which is highlighted in this red box. For ICC removal, cold application with ice around the chest tube entry site was effective in reducing pain, but there was no significant difference in pain was seen with different chest tube size upon removal. Regarding pleural drainage, so during therapeutic drainages, there's no difference in active drainage or applying suction to gravity-driven large volume thoracentesis. So this was proven in the two studies from America that's published in Chest 2020 as well as 2024. And in terms of IPC drainage, one study found that pain was significantly higher with drainages via a vacuum suction compared to manually with a syringe. So if it is just a summary of adverse events of interventions and their frequency in this review, I think I'll just highlight the more relevant ones. So for propofol and midazolam, hypertension was the most common adverse effect, with higher rates seen with propofol use. And with regard to size of catheter drainage, displacement was more common in smaller bore ICCs, and it's likely with some of the older studies, they were not sutured in or anchored in place. So I guess the limitations of the studies included that the sample size was small, the majority of the studies, and there was a lack of comparison groups, randomization, and blinding. There was also significant variation in time points at which the pain was assessed. And pain was also not always the primary outcome measured. There's also, and in terms of discussion, so we know that intrapleural anesthesia and adjuncts is effective in several several procedures, including thoracoscopy, pleurodesis, and ICC insertion. Bupivacaine has a longer duration of action than lidocaine, which is important to consider, as analgesia is often required over a few days. Paravertebral blocks were also shown to be more effective than local anesthesia alone in thoracoscopy. However, the use of paravertebral blocks in intrapleural anesthesia has not been translated to clinical care for routine use, except in some centers, some expert centers. NSAIDs are just as effective as opioids in pleurodesis, suggesting that NSAIDs should be included in the pain management algorithms without fear of reducing pleurodesis efficacy. Small bore intercostal catheters are less painful than large bore, likely explained by the close correlation of chest tube size and insertion method, as well as structures that a larger chest tube may impinge on. TENS and cold application provided better pain relief and control, but currently do not have place in routine practice. Um, the green whistle demonstrated promising analgesia, but requires further comparative study. So the several factors influence pain, and especially so procedural factors, which would be chest tube size, the operator's technique, patient positioning, and dose of the local anesthetic. Um, Now, this can be altered by the physician to minimize pain. However, patient factors such as pre-procedure anxiety, previous experience, and disease severity cannot be controlled for. So all of these factors must be considered together when deciding what analgesia to use. Pain scales have limitations, and the minimum difference in pain outcomes that determine clinical relevance is still unclear. Therefore, it is difficult to determine if the significant differences in pain scores for the intervention described are of clinical significance. Um, there's also a lack of uniformity on the anchor descriptor terms and inconsistency in their interpretation, um, which raises the need for more standardized scales to accurately assess pain in plural procedures. So, because of the variability of individual plural procedures and outcome measures, the one-size-fits-all framework for pain control may be challenging to apply. So it is important to acknowledge of the analgesic intervention is as clear as uniform as possible, given the increasing number of procedures being performed. Despite pain being a significant problem, there remains a need for for better pain management protocols. And I think further research should be targeted to a standardized pain measure, developing more consistent pain management algorithms that accommodate individuals and procedure characteristics. So, most likely a multimodal framework for pain control from the start of the procedure till the chest tube is removed, and also managing patient factors that may impact pain, such as anxiety, pre-procedural anxiety. Um, the other thing is also patient-driven analgesia use, inhaled medication, or a PCA, and that I think can play an important adjunct to pain management in our patients. So I'll end it there for any questions. Thank you.
Perfect. Thank you so much, Sanjeevan, for that detailed talk and review of the literature. That's really helpful. I mean, I think you're right in terms of trying to, pain is not a one size fits all. Pain management is not a one size fits all. So I think you're absolutely right, and that you have to really take care of a lot of the different factors and take those into account. And as we kind of await for any questions from the audience, one of the things that I think one of the drugs you didn't mention, and I put my ICU hat on when I talk about it, but ketamine, I think, more an up and coming kind of, at least in ICU settings and the ED settings, utilizing it a lot more. Any comments on if you've used it or kind of your experiences with it, if at all, or what your thoughts are on ketamine use for pleural procedures, at least intraprocedurally?
I've only used I've not used ketamine since I've been back in Melbourne. I've used it once or twice when I was in emergency in Charlie's, um, and it does work very well. Um, it's just from a logistics point of view, as a day procedure or um, during inpatient, or in the ward, it will be harder. I don't know how much monitoring they would need while they are on ketamine. It does. Yeah. I mean, when I've there's handful number of times we've used it. It worked quite well in the acute setting in the emergency
Yeah,
department. Because it gives you a disassociative effect, right? Is that the
exactly.
way? Yeah.
Yeah, and so,
Um,
I mean, I think you're right that, in terms of the monitoring, that needs to be in an appropriate place. So I absolutely agree with you about that. But one of the things that, again, from a physiologic perspective, is that it doesn't have that hemodynamic effect that propofol and even dexmedetomidine do. So I think that's one of the good utility of it. So,
yeah.
right. Yeah. So there's some questions coming through here. So first question is, do you think use of sedation for the procedure makes a difference to later pain scores?
That's a good question. I think it may in the first 24 hours. It just hard to know because of the heterogeneity in the studies that we've looked at. I very rarely use procedural sedation. I think if we and I think if the anesthetic, local anesthetic is done properly in the right places, generally the patients are it's not as painful. But it's more so. My main interest is looking at what happens after the catheter is in for the 5 days that they have a catheter in for, and how much. And I doubt, I just anecdotally, I doubt sedation per se makes a major. Sometimes I feel sedation is treat the doctor more than the patient sort of effect. So I don't entirely know. And also, how much of sedation do you give? There's no. You're always you're waiting for the patient to grimace in pain before you give more sedation. You might give 2 milligrams of Medas and 50 milligrams, 50 mics of fentanyl. The patient might still be awake, or they might totally zonk out. Like, who actually knows?
Yeah.
I don't know how much sedation itself, how much of impact it makes. I might have the anxiety effect, which may lessen the compounding factor of how they feel pain. I'm not sure. Um,
Yeah, yeah.
but I rarely use, a handful of times that we'll use sedation for all of the most of procedures.
Yeah. And I think just to add on to that, I was always trained that it's better to treat the pain up front than to try to chase it. And so I think that that's one of the big things I always try to teach my trainees is that you want to make sure you control pain up front. So if you anticipate a patient's going to have, if the pleural space is very involved and they're already having a ton of pain, probably pre-medicating with something either oral or something probably useful, as well as local anesthetic has kind of been my practice with that. But I think the big thing I've always taught is that instead of chasing the pain, if you get ahead of it, it's so much easier and better to manage for the patient. So, and then along that lines, the next question is, do you pre-medicate with oral analgesic before talc? And also same question about other bedside procedures. Um, Thoughts on that, Sanjeevan?
Um, so I don't have so case by case basis. We tend to pre medicate, depending on how, and mainly driven by how anxious the patients are. I think more so, I tend to be a bit more aggressive with the pneumothorax patients compared to the malignant infusion patients. They seem to have more pain, and I presume is related to how thickened the pleura is. And as a pneumothorax patient, don't have a diseased pleural space per se, of parietal pleura. So I generally pre-med based on anxiety levels. What we been more routinely doing over the last um, 12 months, 12 to 18 months is getting our anesthetic colleagues to come with us or help us when we're doing um, during the pleurodesis with the green whistle. So we've been using the green whistle for most of our pleurodesis methods on top of the intrapleural lignocaine. So we only give lignocaine for 10, 15 minutes as per the uh, time one time one study. Let it sort of sit in for 10, 15 minutes, and then the patient had the green whistle, and then we'll inject the parietal pleura. So that circumvents the acute pain. But pain often in pleurodesis tend to happen 24, 48 hours later as well, and that still goes with opioids um, and Nurofen, and but that's what we tend to do. The other thing with intrapleural analgesia, I find works much better when the lung is fully expanded rather than when you have not you don't have full lung apposition. I don't know whether because it just collects in one area or what exactly why that is. But even when we do it for patients who have TPA, when they have quite severe pain, when we do give intrapleural lidocaine, it tends to work much better when a lot of the lung is or there's very little fluid, or the most of the lung is fully expanded.
Right. Yep. And along you kind of mentioned the green whistle, but the next question is, have you used the green whistle and found it beneficial when the drain is in situ? So post-procedural kind of management with the green whistle?
Yeah. No, but that's our next study. We sort of wrote the protocol, but haven't acted upon it. One of the issues with green whistle is the hospital policy needs. One of the Sydney groups, I think Taj, has used the green whistle and is currently, and they do use the green whistle on a day-to-day basis for when they do the procedure itself for medical thoracoscopy, IPCs, and ICC insertion during the procedure, which has worked well. Um, in terms of while the catheter is in is what I want to look at using the green whistle, but the problem with using the green whistle is the accumulative toxicity with the agent, which is a theoretical risk, but can happen. You can't overdose on it. The second thing is our hospital policy requires a health professional to be on the bedside while the green whistle is being used. So I think the next step would really be patient-centered analgesic use. But what the best method is, PCAs are good, but the problem is PCAs, you're hooked up to another line,
Right.
which makes them less mobile. So the green whistle is the agent of choice, whether it's that needs to be studied.
Sure. All right. And then another question we have is any non-pharmacologic methods to control pain? So I know you mentioned a little bit about using cold ice or kind of cold therapy and then TENS unit. So besides anything else different or just commenting on those two?
Uh, no, so again, patient factors will, when you sort of get a feeling that you're a bit anxious, sometimes free medication to help. So obviously an IPC removal is quite different from an ICC removal. A pigtail might be more painful than a standard chest drain, depending on and large bore catheters can be also be more painful. So we still use pre-meds for some patients. The cold application is extremely useful. But there's a technique to it, and you have to get the temperature to the right, the skin temperature to a certain temperature for it to be effective. I can't remember on top of my head when the 18 degrees, it's what's in my head, but I don't know if that's the right number. But there is a number that's required for when you put cold application to the site, but that has shown to significantly reduce pain upon ICC removal. So I think cold application would be the most useful method, which like a nurse on the bedside can do, but there is a protocol or technique to do it.
Great. Okay, so we are at about the time. So Sanjeevan, I just want to thank you again for the great lecture and answering a lot of these questions. I think we've approached a really important topic, especially we do all these procedures and so pain is definitely something that we deal with for our patients on a day-to-day basis. So I think a very important topic to better understand and better kind of give importance to. So thank you for that. And before we leave, what I will say is. Just as a reminder, these lectures are uploaded to YouTube, so please, if you weren't able to join in or you missed some of it, please check us out online afterwards. We usually get these uploaded relatively quickly, so follow online. And for next month's, we have Dr. Abhinav Agarwal from the States, a good friend and colleague that's going to be presenting a topic with us. So please join us for that. And remember that the timing will be 1 p.m. Australian Western Time for this next month, and we look forward to seeing you then. Take care and thanks.
Thank you. Thanks.